Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 15, where we're going to be looking at treatments for schizophrenia and other severe mental disorders. So, when we think about treatment for schizophrenia and other severe mental disorders, it's important to remember that the treatment picture is going to vary from person to person, situation to situation, and the presence of one or more mental illnesses. It's also going to dramatic differently for the individuals, the couple, the family as systems, as well as the larger society. The way that we treat schizophrenia and other severe mental disorders today is vastly different than it was 20, 30, 40 years ago. And the more we have learned from research, the more we have realized what treatments actually work for those who have severe mental health disorders. The mental disorders are still, severe mental disorders, I should say, are still very difficult to treat. Only about 40% of people with schizophrenia receive adequate care. And this chapter is going to look at treatments from a historical perspective as well as today. So let's first take a look at institutional care in the past. So in 1793, there was this move from asylums towards large mental health hospitals. There was this shift towards moral treatment with sympathy and kindness. And public mental hospitals or state hospitals were established for patients who couldn't afford private care. It's also important to note that because patients failed to respond to traditional therapies, the primary goal of these hospitals were to restrain them and give them their basic necessities like food, shelter, and clothing. The move towards institutionalization back in 1793 began with the presence of what was considered quote unquote moral treatment. Hospitals and asylums were located in really isolated and desolate areas to protect patients from the stresses of daily life and to offer them a healthy psychological environment. States throughout the US were required by law to establish public mental institutions or state hospitals for patients who couldn't afford private care. Unfortunately, as we are seeing in the mid 50s, there were problems with overcrowding, understaffing, and poor patient outcomes, which led to the loss of individual care and the creation of what are called back wards. These were human warehouses that were filled with hopelessness. The most common pattern of decline was social breakdown syndrome, extreme withdrawal, anger, physical aggressiveness, and loss of interest in personal appearance and in functioning. Many people who would have been placed in psychiatric institutions in the past now reside in other settings, including group homes, nursing homes, and even prisons. There was a conversation that I had had with an assistant warden of a Montgomery County, Pennsylvania jail system, who said about 70% of the people in his jail, and he has on average 800 people at any time, have a severe mental health issue. It's a really high number. And he's been working in the Montgomery County prison system for almost 30 years. Mental health care is typically minimal in many of these places, like nursing homes, in some group homes, and even prisons. So, a lot of people have talked about lobotomies. Is it something that we should continue doing, and is it something that can actually be helpful? Well, a lobotomy was first performed in 1935, and it was where there was a needle that was inserted through the eye socket and then rotated to destroy tissue. It was often done in conjunction with the ludotomy, which is where there were two holes that were drilled into either side of the skull, and there was an instrument that resembled an ice pick that was inserted into the brain tissue to cut or destroy the nerves. So by doing these two things at the same time, they could help to alleviate some of these symptoms that people were experiencing. Unfortunately, it would cause things like brain seizures, weight gain, loss of motor coordination, partial paralysis, incontinence, endocrine malfunctions, and also responsiveness that was not ideal, both in the intellectual and emotional realms. And lobotomies were things that were used until the discovery of antipsychotic drugs. This helped put an end to this practice, and this practice today is not used very widely. So, into the 50s, 1950s, we now see that there's institutional care that takes a turn for the better. So there were two new institutional approaches that emerged. One was called Milw Therapy, and this was created by a psychologist named Maxwell Jones. And in Milw Therapy, Jones said, you know what? Institutions can't help patients unless they create some type of social climate that promotes productive activity, self-respect, and individual responsibility. Residents have to live in a therapeutic community, and it must include respect, support, and openness, which is what we see outside of the institutional settings in you and mine in all of our everyday lives. This approach, as well as the second approach that we're going to talk about, which is the token economy, particularly helped improve the personal care and self-image of patients. And these were problems areas that were worsened by institutions. So the premise is that institutions could help patients make clinical progress by creating a milieu or a social environment that talked about productive activity, self-respect, individual responsibility with regards to respect, support, and openness. And by doing this, it there was a lot of research that showed that patients, especially with schizophrenia, in milieu programs often left the hospital at higher rates than patients who received just basic custodial care. In addition, milieu style programs have been set up in institutions throughout the Western world with moderate success. The second is a token economy. So, what is a token economy? Well, this is based on operant conditioning principles. Token economies are used in institutions to change the behavior of patients with schizophrenia. Patients are rewarded when they behave in socially acceptable ways and are not rewarded when they behave unacceptably. Immediate rewards are tokens that can later be exchanged for things like food, cigarettes, privileges, and other desirable objects. Acceptable behaviors likely to be targeted include things like care for oneself and care for their possessions, going to a work program, speaking normally, following the rules, and showing self-control. Researchers have found that token economies help reduce psychotic and related symptoms. Token economies have helped improve the personal care and self-image of patients in problem areas worsened by institutionalization. And they're still used in many mental hospitals today, usually along with medication. And this approach has been applied to other clinical programs. However, there are questions that have been raised about these programs. There are research studies that have been uncontrolled. Instead of patients being randomly assigned into groups, a whole ward will participate in the program. Are such programs ethical and legal? Aren't all humans entitled to basic rights, some of which are compromised in a strict token economy system? Are such programs truly effective? For example, patients may change overt behaviors, but not underlying psychotic beliefs. And transitioning from a token economy to a community living may be difficult for some patients. In the 1950s, we also discovered antipsychotic medications. So researchers had developed antihistamine drugs for allergies, but found that certain antihistamines that were used to calm patients about to undergo surgery could also, or that these antihistamines could also be used almost like an anesthesia to help calm patients about to undergo surgery. Chlorpromazine was tested on patients with psychosis, and they found that there were a reduction, a pretty significant reduction in symptoms. In 1954, chlorpromazine, I always mess that up, I apologize, also known as Thorazine. This was approved for sale in the United States as an antipsychotic drug and was very successful. After that, there were other antipsychotic drugs which were since found. So since the discovery of these antihistamines, there were other kinds of antipsychotic drugs that were developed. So those developed throughout the 60s, 70s, and 80s are now referred to as quote unquote conventional antipsychotic drugs or first generation drugs. These drugs are also known as neuroleptic drugs because they often produce undesired movement effects similar to symptoms of neurological disease. Drugs developed in recent years, so from the 1990s to present, are known as quote unquote atypical or second generation antipsychotics. So what are the effectiveness? Well, symptoms are shown to be reduced in about 70% of patients who are diagnosed with schizophrenia. and it's more effective than any other approach that's used alone. In most cases, the drugs produce the maximum level of improvement within the first 6 months of treatment, but symptoms may return if patients stop taking the drugs too soon. Positive symptoms of schizophrenia are reduced more completely or more quickly than negative symptoms. So, what were some of the unwanted effects of first generation antipsychotic drugs? So, there were these extrapyramidal effects, and they were almost like Parkinson and related symptoms, which was a result of the medication induced reductions of dopamine. There were also neuroleptic malignant syndrome, which was a almost fatal reaction, especially in the elderly, and tardive dyskinesia. So, in addition to reducing psychotic symptoms, conventional antipsychotic drugs sometimes reduce disturbing movement problems. And these extrapyramidal effects appear to be caused by the drug's impact on the extrapyramidal areas of the brain. The most common of these effects produce Parkinson's symptoms, reactions that closely resemble features of the neurological disorder, like muscle tremors and rigidity, bizarre movements of the face, neck, tongue, and back, greater restlessness, agitation, and discomfort in the limbs. The Parkinsonian and related symptoms seem to be the result of medication-induced reductions of dopamine activity in the basal ganglia and the substantia nigra, parts of the brain that coordinate movement and posture. In most cases, the symptoms can be reversed if an anti-Parkinson drug is taken along with the antipsychotic agent. Sometimes the dosage must be decreased or the medication must be halted altogether. In as many as 1% of patients, particularly those who are elderly, conventional antipsychotic drugs produce neuroleptic malignant syndrome, which is, again, a severe and potentially fatal reaction. The symptoms include muscle rigidity, fever, altered consciousness, and improper functioning of the autonomic nervous system. As soon as the syndrome is recognized, the drug is discontinued immediately, and each symptom is treated medically. Individuals may also be given dopamine-enhancing drugs. A more difficult side effect of conventional antipsychotic drugs appears up to 1 year after starting the medication. That is tardive dyskinesia. This involves writhing or tick-like involuntary movements, usually of the mouth, lips, tongue, legs, or body. And tardive dyskinesia can be difficult and sometimes impossible to eliminate, especially when taking antipsychotic drugs. When prescribing first-generation antipsychotic drugs, clinicians are now more careful in how they will prescribe. They typically will start at the lowest dosage and gradually reduce or stop the medication weeks or months after the patient begins functioning normally. In addition, like with second generation antipsychotic drugs, they also will do rigorous testing to make sure that this isn't impacting the functioning of organs like the kidneys and liver. So now let's take a look at second generation antipsychotic drugs. So these biological operants will differ from first generation agents because with second generation antipsychotic drug, they are received at fewer dopamine D2 receptors, and they're also received more at the D1, D4, and serotonin receptors than first generation antipsychotic drugs. It's at least as effective and often more effective than first generation agents. It helps to reduce positive and some secondary symptoms and causes fewer extrapyramidal symptoms and much less tardive dyskinesia, which again, tardive dyskinesia is attached to the D2 receptors. The most widely used second generation antipsychotic drugs include clozapine, which is the generic for Clozaril, risperidone, which is the generic for Risperdal, olanzapine, which is the generic for Zyprexa, quetiapine, which is the generic for Seroquel, zipristinone, which is the generic for Gedon, and aripiprazole, which is the generic for Abilify. When we look at some of the newer antipsychotic drugs, the biological operation differs from that of even the more conventional antipsychotics because they're finding that they not only are more effective at these antipsychotic as first or second generation antipsychotic drugs there's fewer negative symptoms. It causes even less extrapyramidal side effects and less likely to cause tardive dyskinesia. Unfortunately, a lot of these atypical or newer antipsychotic drugs will carry a risk of life-threatening drop in white blood cell counts, which is why every 2 to 6 weeks, on average 4 weeks, there has to be blood work that is drawn to ensure that it's not only looking at the white blood cell count, but we're also looking at the functioning of the kidneys and the liver. Some of the other side effects of these antipsychotic drugs include weight gain, especially in the midsection, dizziness, and significant elevations in blood sugar. And again, whenever someone is taking an antipsychotic drug, whether it's first generation, second generation, or the atypical and the newer generation of antipsychotic drugs, if there are side effects, they will treat each side effect medically and treat them each differently. So what we see here are first and second generation antipsychotics. So on the left with first generation antipsychotic drugs, they're more likely than second generation drugs to produce undesired extrapyramidal symptoms. So what you see on the left is the dose response curve for the first generation antipsychotics that show that beginning with low doses of the drug, extrapyramidal side effects emerge and keep intensifying right along with increases in the drug's dosages. When you look at B, the dose response curve for the second generation antipsychotics indicate that extrapyramidal side effects typically don't even appear until a patient is taking relatively high doses of the drugs. In addition to taking a medication regimen, psychotherapy is something that is used today. But early psychotherapist treatment was rare before antipsychotic drugs emerged. Again, they essentially put them into an institution far away from everyone and everything, and that was it. So today we use psychotherapy with schizophrenia treatment, and it's been shown to be successful when they are taking medication in conjunction with cognitive behavioral therapies and sociocultural interventions, specifically family therapy and social therapy. So let's talk about cognitive behavioral therapies. So there's this notion of cognitive remediation. This focuses on difficulties that many patients with severe mental health issues, including schizophrenia, have, where they have difficulty with attention, planning, and memory. And part of the cognitive remediation is DBT will look at increasing more complex computer tasks until planning and social awareness tasks are reached. And it provides for moderate improvement in things like attention, planning, memory, and problem solving. And it extends to the client's everyday life and social relationships. There's also a form of virtual therapy that's used. So in the cognitive behavioral therapy realm, they will look at hallucination reinterpretation and acceptance. Therapists will help change how clients view and react to their hallucinations. And there's also a combination of behavioral and cognitive techniques that are going to be utilized. So in this form of therapy, clients have, or clinicians have the clients interact with a computer-generated on-screen virtual human being. An example of that is the picture on the right. And this would be representative of their hallucination. Typically, it is a person or an object or something that would come up on the screen. And what they will do is therapists will help change how clients view this depiction and how they will react to their hallucinations. The collective results of studies suggest that confronting one's hallucinations in a virtual world can help at least some people with schizophrenia to be able to manage this more effectively. When we look at the combination of cognitive and behavioral techniques, we're going to find that there's a lot of psychoeducation that is going to be given. This is going to be education about the biological causes of the hallucinations, as well as some of the unpleasant sensations they may experience, not only as a part of their hallucinations, but also as part of their coping skills. There's also going to be identification of events and triggers of these hallucinations, challenging the inaccurate ideas that the hallucination's power has over the individual, and look at how we can more accurately interpret these hallucinations. Some of the newer wave CBT techniques are looking at how we can help understand hallucinations as being part of them and accept them rather than misinterpret or overreact to them. And a lot of what we do today is to help clients accept their stream of problematic thoughts and gain a greater sense of control. So when you help them gain a greater sense of control over these hallucinations or delusions, they can become more functional and they can move forward in life. And by looking at it more as a stance of understanding and accepting that this may be part of their life and how can we still keep moving forward around this, can actually be more helpful in reintegrating part of themselves into their everyday life in a healthier way. So maybe they might see more functioning in the ability to manage their own ADLs or activities of daily living. You may be able to see them work a part-time job, maybe 5 to 10 hours a week, whereas before they wouldn't be able to. When we think about family therapy, remember that someone with schizophrenia isn't just impacting the individual, it's also impacting the family system. So if someone has schizophrenia or another severe mental disorder, it impacts the lives of family members. And in many cases, they end up living with those family members, and it can create a lot of stress. It's also been shown through studies and self-reports that those who are impacted with severe mental health issues, who live with relatives, who display high levels of expressed emotion are at greater risk for relapse than those who live with more positive or supportive family members. So what can we do in family therapy? Well, we're going to address these family-related issues and stressors, create more realistic expectations for the family as a whole, and provide psychoeducation about the disorder or comorbid disorders that may be impacting this individual. Families are also going to be given information about potential family support programs and psychoeducation programs so that they can gain better understanding of the severe mental health issue or issues that are impacting their loved one. Research support for the usefulness of these popular groups hasn't yet demonstrated full effectiveness. However, self-reports have shown for it to be helpful. In social therapy, this is essentially personal therapy, and we're going to address the social and personal difficulties in our clients' lives. We are going to look at practical advice, problem solving, decision making, social skills training, medication management, employment counseling, financial assistance, and possibly housing. And by looking at social therapy and using individual and group therapy in order to address these skills and more, we are finding that it's not only helpful for our clients for longevity, but it also helps to reduce rehospitalization for mental health related symptomology. It's also important that we look at the community approach. So in 1963, Congress passed the Community Mental Health Act. And this was passed partly in response to the terrible conditions in public mental institutions and partly because of the emergence of antipsychotic drugs. So under the Community Mental Health Act, or CMHA, this ordered that patients with a variety of psychological disorders should be released and treated within the community. And it stipulated that patients should often be offered a range of mental health services, so not just counseling, like the ability to see a counselor, the ability to see a case manager to help manage, all the things that they need in their life with things like housing and, setting up doctor's appointments and even supporting with job support. Also getting connected with a psychiatrist who can administer these medications, getting connected with a peer support specialist who can help navigate the world, because a peer support specialist has been a part of that world, but they are in recovery. And when we think about this, there were good intentions in passing this act. Unfortunately, though, there is some poor quality community care specialists and services, or a lack thereof. So unfortunately, community care has created a revolving door pattern for many patients. They will go to the hospital and they will do their time in a mental institution. They'll be stable enough to be released to the community. They'll go to a treatment center and stay at a treatment center for, say, 12 to 24 months, and they will do well. And then they will, for example, maybe get a housing voucher so they can get their own apartment. And then you find that they stop taking their medication. And if they had a job, they're no longer going, or if they volunteered, they stop volunteering. and you find that they go back to their old ways. And then they may be found and involuntarily committed back into the hospital, and the cycle continues. So, what are the features of effective community care? Well, first of all, there needs to be coordinated services. This is going to be making sure that there's a counselor, a social worker, a case manager, and a psychiatrist, and possibly a psychologist all on board, as well as a primary care physician. And also making sure that if there are other comorbid issues, say with substance use disorders or with things like eating disorders, that those treatment specialists are involved as well. There also needs to be communication between an agency and the providers, as well as the local hospitals, so that we can make sure that anytime someone who has a severe mental health issue is, placed back into the care of the hospital, that they have the supports that they need and that everyone is fully communicating with each other. People who are recovering from schizophrenia and other severe mental health issues, they're going to need things like medication, psychotherapy, help in handling daily pressures and responsibility, guidance in making decisions, social skill training, residential supervision, and vocational counseling. So, to have all of this addressed, um, this is a combination of services. It's called assertive community treatment. And this is where we are really pushing in order to have this community treatment that is, in fact, more assertive and effective. We also need to talk about short-term hospitalization because sometimes treatment on an outpatient basis is not successful. And when that's the case and they're in danger of harming themselves or others, they may be transferred to a short-term hospital program. So what happens is they will go to a local hospital to be medically evaluated, and then they will go inpatient to a psychiatric ward. And after they're hospitalized for typically 2 to 4 weeks, they are released into an aftercare program to follow up within the community. And part of that aftercare program in the community, this assertive community treatment, will address all the things that I just mentioned. We also have partial hospitalization, and this is where a patient may fall between needing full hospitalization and outpatient care. So, this is where they may have programming during the day, like group programs, to help them with understanding some of the skills like making decisions, social skills training, and even vocational counseling, as well as therapy. These programs provide daily supervised activities and programs to improve social skills. They also work to help bring structure to their life. They have a residential crisis center, usually on the campus or in the facility, and they provide 24-hour care for patients who have severe mental health disorders. They will either have a nurse on staff or a nurse on call, and they will have staff members who are available at a low ratio. Typically, it's 2 to 3 clients per individual to help with providing the care that they may need. So, there's also supervised residences. They can be halfway houses or group homes or part of the program, but they provide shelter and supervision for patients who are unable to live alone, who cannot or do not want to live with their families, and who don't require hospitalizations. So the staff members are usually paraprofessionals. They're trained in things like first aid and CPR. In some cases, they may be trained in restraints. And these houses are run with the Milw Therapy philosophy, and they help persons with schizophrenia and other severe mental health issues to adjust to community life. And the goal is to minimize rehospitalization. Also, occupational training and support. So, there are typically going to be paid employment opportunities that can help provide income, independence, self respect, and the stimulation of working with others. So, in these cases, especially with those who have schizophrenia or other severe mental health issues, they may receive occupational training in what are called sheltered workshops. These are supervised workplace for employees who are not ready for competitive or complicated jobs. And they'll do things like help put together the boxes for Comcast or for Comcast, who when someone decides to have internet at their house and they're going to install it themselves, individuals with schizophrenia may have helped to put those boxes together that are shipped to your house. Or when you look at flip flops, for example, from Old Navy, where you have piece of material between the big toe and the second toe, and it's pushed through the bottom of the shoe. There's a lot of individuals with schizophrenia in the area who may have helped to do that. So the sheltered workshop is this alternative work opportunity with someone who has severe disorders to have supportive environments where they can earn money and again develop their sense of independence and self-respect and get used to working with other people, excuse me. Unfortunately, this type of assistance is not consistently available all the time. And especially with a lot of the funding cuts that we've seen in recent years, these shelter types of workshops are the first to go. When we look at community treatment failure, something to remember is that fewer than half of all people who need them receive appropriate community mental health services. In any given year, 40 to 60% of all people with schizophrenia receive no treatment at all. What are the two reasons why? Number one is poor coordination of services, and number two is a shortage of services. So, what are some poor coordination of service challenges? Well, mental health agencies typically in a community often fail to communicate with one another. In order to combat this problem, there's a growing number of community therapists that have become case managers for people who suffer with things like schizophrenia and other severe mental health issues. Case managers offer therapy and advice, teach problem solving and social skills, and ensure compliance with medications. Case managers also try to coordinate available community services for their clients, guide them through the system, and protect their legal rights. When we talk about the shortage of services, unfortunately, there's an inadequate number of community programs that are available for people who have schizophrenia or other severe mental health issues. And a lot of this is because there's just not enough funding to keep these programs going. There's also an economic reason for the service shortages. Number one, there's less funding for people who have severe disorders. And number two, program funding often falls to local governments and nonprofit organizations, not community programs. What are the consequences? Well, many people with severe mental health issues, including schizophrenia, may receive no or inadequate treatment. Many people will typically be prematurely discharged, have inadequate follow up treatment, and their housing settings may vary. Many patients return to their families and receive medication and perhaps emotional or financial support, but little else in the way of treatment. And unfortunately, many people with schizophrenia do end up homeless every year. So, where do people with schizophrenia live? More than one third live with unsupervised residences. 6% are in jails and 5% are homeless. Approximately 8% of patients enter an alternative care facility, such as a nursing home, where they receive custodial care and medication. As many as 18% are placed in privately run residences where supervision is provided by untrained individuals. Another 34% of patients are placed in single room occupancy hotels, generally in rundown environments where they survive on government disability payments. So, research indicates that clients in effective community programs make more improvements than those in other kinds of treatments or poor community programs. Worldwide, we need well coordinated community treatments to be seen as a crucial solution to the problem of severe mental health dysfunction. In order to treat people effectively, we need to see improvements in quality of life and symptom reduction. When we can achieve those two things, can we then be able to have these individuals be more productive members of our society and be able to function at their best? Until then, we are essentially throwing a band aid on a gushing wound that needs more stitches and care. I hope that this was helpful. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. Also, don't forget in the description box below is this week's extra credit um, opportunity. All you need to do is answer the question in the comment section below, take a screenshot, and upload it to Canvas by Sunday at 11:59 p.m. for up to 1 point added to your final grade. Until next time, I hope you have a great one and be well.